Public Health. Now we are a Department of Public and Global Health. So I'm a lecturer at that in the department. Today we are going to present to you some work that has been done on COVID-19, uptake and adherence to COVID-19 public health measures in rural and urban Kenya. It's a small study that has been conducted by one of our colleagues, Dr. Ongore. Dr. Ongore is a public health physician and a senior lecturer, disease prevention and control, Department of Public and Global Health at the University of Nairobi. He holds a Bachelor of Medicine, MB-CHB, University of Nairobi. He's an alumni of our department, Master of Public Health, and he also holds a PhD from Liverpool School of Tropical Medicine in the UK. Yeah, so Dr. Ongore has been in our department for over 35 years, so he has a lot of experience, and he has also worked with the WHO as a consultant epidemiologist in the Ministry of Health in the government of Eritrea in one of the projects on integrated disease surveillance. So he's also the founding director of One Health Central and East Africa. So Dr. Ongore, welcome to the team. Dr. Ongole will be assisted by one of our colleagues also, Dr. Susan Nyawade, who is also an honorary lecturer within the Department of Public and Global Health. So Dr. Ongore, if you are ready, the floor is yours.
Okay. Thank you, Dr. Pamela Godia, for that introduction. I hope you can see my screen.
Yes, Dr. Ongore, we can see your screen.
Yes, if yes, I thank you very much. This study was supported by a grant from the One Health Regional Network for the Horn of Africa, HORN. And these were the investigators, myself, Professor Ngombe, and Susan Nyawade, who is with us today. As we know, as of December 2019, diagnosis of a pneumonia of unknown etiology was made in China among patients who were linked to South China seafood, Hunan and Wuhan. Subsequently, the disease was linked to a virus which was initially named as 2019 novel coronavirus, 2019 nCoV, and subsequently named COVID-19 and given the current reference name of severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2. Again, several public measures that may prevent or slow the transmission of COVID-19 were introduced, including case isolation, identification, and follow-up contacts, and so on. And in particular, the use of face masks, covering coughs, sneezes with tissues. These are all that are known to us. Others were avoidance of contact with infected people and maintaining an appropriate social distance. The government of Kenya, in response to the COVID-19 pandemic, implemented a raft of recommended public health measures to prevent the spread of the disease within its borders. The extent of uptake and adherence to the recommended public measures against COVID-19 at that time were not entirely known with certainty. Therefore, a study was undertaken to determine the factors associated with uptake and adherence to recommended public measures against COVID-19. The study was conducted in a rural setting, Sigomre Ward, Gunja Sub-County, Siaya County, and in an urban setting in Ngong Ward. Ngong Ward is part of Nairobi metropolitan area. It's in Kajiado North Sub-County, Kajiado County. That was the urban setting. And the main objective of the study was to determine the factors that influence the uptake and adherence to recommended public health measures by the population community against COVID-19. This study was conducted in strict adherence to COVID-19 measures. A quantitatively structured questionnaire was used to obtain the information, and the questionnaire was mounted on the ODK platform and administered by telephone interviews. So it was a cross-sectional analytical study in one electoral ward in each rural and urban communities in Kenya. At the beginning, an enumeration list with mobile telephone numbers was obtained in the two wards. In the urban area, the enumerators were able to enroll more than 5,000 households, while in the rural ward, the village elders were able to enroll more than 7,000 households with mobile telephone numbers. From the list, samples were obtained by stratified systemic sampling from the individual villages in the two wards. So a total of 387 households were enrolled. You may wonder why. Sample size was calculated because there was no information. So a sample size of 384 was suggested. So 387 households were enrolled in Kajiado County, while 432 were enrolled in Siaya County. And that is the household size, 1 to 24, with a mean of 4.5 in Kajiado and 5.1 in Siaya. And that's the overall age of the respondents, ranged from 18 to 94 years, with a mean of 37 in the Kajiado rural urban and 42.5 in the rural. And the leading proportion of respondents was 31 to 40 in Kajiado urban, while it was over 50 years in Siaya. And this is the status of the interviewees. The vast majority of the interviewees were the head in both counties. And on duration of stay, the vast majority of respondents in both areas had stayed in the area for more than 12 months. Gender of the respondents, as expected, the majority of respondents were female overall and in the rural and in the urban areas. Interview level of education, the largest proportion of respondents in both areas, sorry about that, in both areas had attained at least primary level, while secondary level and tertiary level, there were more respondents in the urban compared to the rural. Where did you first hear about COVID-19? The majority of the respondents had first heard about COVID-19 from the media, either the radio, TV, newspapers in both areas. Similarly, almost a similar proportion had heard about COVID-19 from the media. This was followed at a distance by friends, 6% overall, and almost the same proportion in both urban and rural. On knowledge of recommended actions against COVID-19, this is knowledge. The leading response was hand washing with soap and running water. This was followed by wearing a face mask. Staying, working, learning from home was the next, and then hand washing with water only. This was on knowledge. And you can see the distribution there. Leading is wearing face mask, hand washing with soap and water, and so on. Now, most measures against COVID-19 most frequently followed. Leading response again was wearing a face mask, followed by hand washing with soap and running water. The least frequently followed was self-isolating at home, followed by self-quarantine if you suspect you have the virus. Again, the distribution is shown in the diagram there, in the figure there. Most frequently followed was hand washing, wearing face masks, hand washing. And then on the preferred sources of discussion on COVID-19, the leading source was friends during socialization with an overall response rate of about 35% and so on, followed by listening to professional or government officials. And the least preferred source was family sessions with a rate of just about 30%. And this is the preferred sources again, friends during socialization, family, professional. On the number of times per day they listened to information on COVID-19, the leading response was 2 to 5, and the least frequent was less than 5%, was none by less than 5% across all respondents. Again, you can see the distribution there, number of times per day listened to information on COVID-19. What about the news items they expected to get an update on? The leading response was recoveries from COVID-19. And this was followed by the number positive. So recoveries was most up in the people's mind, followed by the number positive for COVID. And then the other category, testimony of positive infected with corona. When is corona ending? Is there possible eradication of corona? Vaccines for COVID-19. When do we resume economic activity? When is the curfew ending? Was the least item to get an update on at only 3.3%. That's the distribution of the number of items to get an update on. Now, most interesting for us, what are the reasons for your action on the recommended public health measures? In both areas, fear of being infected was the leading reason for action, followed by fear of infecting others. It's a bit surprising because most people would think that the government is a government directive and fear of being arrested, but this proved to be less important. So people are more afraid of being infected and infecting others. And these are the reasons for action, as in the figure 11. Then when you ask them, what are the barriers to action, to adhering to those recommended measures by the government? And the leading barrier was that the activity was not practical. Not practical. Other barriers were the high cost, non-availability, and the activity is not reasonable. So again, the leading barrier was the activity is not practical. This is, you can see, not practical is the leading both in rural and in the urban areas in most of the activities. So suggest what should be done to make it easy to implement the difficult activities. In both areas, discuss with the community. Discuss with the community was the leading action suggested to be done to make it easy to implement most of the activities found to be difficult. Others were making resources available and reducing costs. But discuss with the community was the leading action. So, in view of all those results, we thought that there is a need to explore ways of making the radio, the media, radio, TV, newspapers, more interactive with frequent updates on number of recoveries from COVID-19 and number of positive COVID-19. And then the update should be provided at least 2 to 5 times a day. And we thought that the efforts should be made to improve knowledge on proper and practical methods of hand washing with soap and running water to make them more practical. And then the rationale, increase the rationale for wearing face mask, to improve the techniques for wearing face mask, to exploit the reason of the fear of being infected, or if the transmission dynamics. What is the rationale for wearing face mask? Probably that would improve the uptake of wearing a face mask. Hand in hand in that, effort should be made to provide appropriate and adequate information on the infection mode of COVID-19 to reinforce the fear of infection and fear of infecting others. And then practical and appropriate measures to combat COVID-19, because their cry was that the measures were not practical measures. And then there should be an aggressive and conscious effort to engage with communities to make it easy to implement most of the activities found difficult to implement. There was a cry that, yes, you are not talking to us. You need to talk to us. Engage with us. The solution lies with us. So we thought that should also be exploited. So those were the few thoughts that we had on this. This is still very preliminary, but these are some of the areas we wish to share with you. And then we have just a few key references here, including the last one there by Peter Mwangi Kibe and others, who looked at COVID-19 and community healthcare in Nairobi's informal settlement. So thank you very much for listening to me. Back to you, moderator.
Yes, so thank you, Dr. Ongore, for that elaborate presentation on uptake and adherence to COVID-19 public health measures in the rural and urban Kenya. I would like to give an opportunity to Susan. Susan Nyawade, do you have any comment to add on what Dr. Ongore has presented?
Good afternoon, everyone. Nothing new to add. We'll take questions.
Mm-hmm. Okay, so thank you very much, Susan.
Otherwise, this is can you hear me?
Yes, we can hear you.
Okay. Yeah, I have been losing Pamela a little bit, but this is a study we put together some time back, almost at the very beginning, collected a little later, but I think move forward in putting together interventions, even though it was only carried out in 2 places. We know that any response, especially specific, but there's a lot that we can borrow because other studies, as I hand it over back to the moderator, I just noted that there's a question where Tessa was asking whether respondents chose from a range of answers or whether they came up with these responses themselves. And I'd just like to refer back to the presentation where Dr. Ongore mentioned that this was a structured questionnaire. It was basically quantitative, in which case questions are close-ended. And so they had to select from a range of answers. And these options were arrived at from what was already available in the literature, as well as what we were hearing from the communities at the time. So thank you, and back to you, Dr. Godia.
Okay, so thank you, Susan, for your brief comment. So I'd like to open the floor for any questions. Today we hope to have a shorter time for the webinar. So because we only have one presentation, so I would an opportunity for anyone who has a question to, if you can, if you're not, you can type on the chat. Yeah. So I think if you're able, if you would like to make a comment, you should be able to unmute yourself and then give a comment. Yeah. So there's one question from James Okech. She's asking, how did this study compare with other similar studies around the region? So Dr. Ongore, please just take note of that.
Yes.
So I also had a question to ask. You said in your presentation, you said some of the measures that had been recommended either by government or by, for COVID-19 prevention. You said some of the measures were not practical. So are you able to elaborate more on that to see which measures exactly did they indicate that they were not practical? Did you explore that further?
Yes, we did. Measures like hand washing with water, with soap and water, with running water. For example, the availability of running water was an issue. In the rural areas, it is not practical to wash your hands with running water, because water itself is a problem. Issues like social distancing, keep your distance in the urban areas. This was not practical. And even wearing a face mask itself in the urban, and sometimes even in the rural areas, there's a perception that of suffocation. So you're asking us things that are not practical to us. So things like that. But that's what they are trying to refer to, those ones. Now, on the question, how did this compare with other similar studies around the region? In our literature search, similar studies have been carried out in other parts. We found studies in Nigeria that have looked at some of this. From Pakistan, from Saudi Arabia, from Malawi. And the response was generally that these measures are the government measures, and they have not talked to us. This is what some of the literature was saying, that there's not been consultation with us. So it is like them and us. So that was a predominant theme that was coming from some of the studies that we looked at around the region. And in the media as a source of information. What we are finding out in other places was that the social media, there was a lot of use of social media from other countries, as opposed to us, where the measures were mainly from the media, radio, TV, newspapers. So there's more of use of social media outside there compared to us here. And then something else that we were able to capture was that the more emphasis on the numbers, the number positive. Whereas people are more interested in more recoveries. Number positive was also there, but recoveries. So we did look at studies from around the region. We've compared. We couldn't present all of that here, but we have looked at. And our own very study from KEBRA, by the last reference there, was very useful. People are saying, yes, where is the commodity? Water is a problem. You can't get it. So how do you want us to carry out this? Yeah, so these are some of the areas. There's a comment at the bottom there. You noted recently that Nyeri County is one of the urban rural areas which had very high uptake of observing COVID measures. Even so, a market madman wearing a mask. Yes, that is commendable. Yeah, so we have seen people wearing masks on their head as a head scarf. You have seen that in some areas. And in some areas, most of the practice we have seen is below the chin, and we see this even in the city here. So that is a good comment. Yes, you can see some more in the Q&A. Susan, do you want to comment any further?
Thank you very much, Dr. Ongora. You've covered these well, but maybe just a quick one on the question from Dr. Godia. Some of the areas that people felt were either not practical or not reasonable, or maybe not available, like you mentioned, the running water, and sometimes even the what is it called, the sanitizer. So those are areas that people were looking at. And then, you know, like when you tell people to avoid touching their face, nose, mouth, and eyes, they find, you know, it's unreasonable, because this is something that is almost happens involuntarily. Staying away 1 meter or more, as has already been alluded to, self-isolating at home in situations in our settings where so many people are sharing a room or a house, then it becomes very difficult, or they felt that was very difficult. When issues about, you know, maybe staying or working from home or studying from home, again, those are not very practical for the majority. In terms of comparability to other studies, we find that many of the studies really what sometimes we allude to as knowledge may actually be awareness. But even when it comes to practice, you will find that when people are self-reporting and you ask them whether they put on masks or whether they wash hands, you'll find that the percentages or the proportions will be as high as we've seen, where we even have 100%. However, a new way of you know, looking at these further, which maybe we did not do at length in this study, however, has been done in some more recent studies, is that if somebody tells you that they wear masks or they wash their hands, another way to follow up is to find out how frequently they do it. And normally you'll find that if, for example, you have a Likert scale where, you know, very little, very much, or from one end of, you know, the most and the least, you'll find that those who actually practice all the time tend to be much fewer. And so that is one way to know. So yes, I wear masks, but if I wear it once a week, or maybe sometimes, or maybe I wear it in my chin, as has been mentioned, then it becomes challenging. And that is why the need to engage with the population or the community is important, so that we are not just telling them to wear masks. We need to tell them why they need to wear those masks and how this is helping to protect them, as well as how they need to wear them, so that we don't end up with maybe 100% responding by saying they wear masks, when maybe the mask spent a lot of time in the pocket. So as I mentioned earlier, this will be driven by the context, so that you may find that even within an area or a county, for example, or a ward, you may find that there are those who are adhering to what is recommended, whereas others are not. And it is those reasons that we need to address. If the masks are too expensive, how can we support people to have them? If the sanitizer is expensive or not available, what do they do? When it comes to water, it may not just be running water. It might be a situation where people have so little water that they cannot afford to use it for hand washing, and therefore it may be saved for just cooking or real essential areas within the household. So there's definitely much more, and there'll be need to make a follow-up, especially for those questions that are alluding to, what additional questions did we ask? Unfortunately, as I've mentioned, with a structured questionnaire, it becomes a challenge because you sort of, you have the closed questions. But one thing that can be done is to have a follow-up qualitative meeting to explore some of these further, so that we get to understand better and respond with interventions that can address the issues. Thank you, and over.
Okay, so thank you, Susan, for that that response, plus Dr. Ongore. I think I can, looking in the chat, I can see there's a comment there from Tessa, who is saying, I wonder whether the study could have more closely explored the issue if it was less structured. What was the reason for a quantitative study, given that statistical tests have not been performed? I think this section on barriers is very helpful, but I feel like I wanted to understand more, or she wants to understand more about that. I also feel that people may have been inhibited from giving a truthful response, as they are always worried about getting in trouble when dealing with an institution, which is understandable. Okay, yeah, so just expressing the fact that having a different methodology would have maybe elicited more response or more views from community members, as opposed to just the quantitative study alone. Then there's Cecilia there who is saying, did you consider psychosocial factors like level of satisfaction, dissatisfaction as a factor due to depressed economy leading to apathy being one of the unreasonable. Yeah. Yeah. So I don't know, do you have any comment on that? My other comment would be, yeah, do you have a comment on that?
Yes, maybe I can go faster.
Yes, Dr. Ngo.
Yes, thank you. Thank you for those observations, which are very valid. One of the reasons why we didn't do a qualitative and what it was not practical. Remember, this study was done in the midst of the COVID-19 pandemic, when the measures were at almost their height, and it had to be done with strict adherence to COVID-19 protocols. And one of the conditions was that limited contact with the participants. There was no gathering whatsoever, wasn't allowed. So that is one of the reasons why we could not do a qualitative study. Remember at the beginning I said the questionnaire was mounted on the ODK platform, and it was administered using Android-enabled mobile phone to deliver the questionnaire. So it had to be delivered remotely. So discussion was very limited. Big part of the COVID-19 regulations. And as my colleague has alluded, there will be need, there could be need to follow it with more qualitative study to bring out the more in-depth information. So it was limited. And one of the lessons we learned was how to carry out a study during the COVID-19 remotely. Just like we are now talking to each other remotely. We are able to deliver a study remotely with the strict adherence to COVID-19 regulations. Psychosocial factors, we did not quite look at those psychosocial factors directly, but they may have come out indirectly in some of the results. So maybe over to Susan, that's the least I can say about the qualitative as opposed to quantitative study. Susan, do you have anything to add?
Not much. I think you've covered that well, but just to add that we're also interested in getting some rapid results and also quantitative, because then when you hear from many people, you might be better able to determine. But when it comes to understanding the whys, then you have to go into the qualitative. And as I mentioned, qualitative tends to be, even more context specific. It is difficult to then maybe generalize. And it also is labor intensive, among other issues, as has already been alluded to. So in terms of the level of life satisfaction, dissatisfaction, we may not have looked at this, but I think I've seen subsequent studies that have looked at maybe not so much level of satisfaction, but the fact that the economy, made people concerned. For example, in our case, I know in the presentation, we have alluded to some of the reasons why people either would not be able to follow the measures. And in terms of economy, you would only find issues around maybe the cost, etc. But we've seen other studies where people are continuing to go out to work or to go into public transport, etc., because they must continue feeding their family, they must continue earning a living. Otherwise, in terms of this specific one, then I believe it is something that can be followed up in subsequent studies. Thank you.
Okay, thank you. Thank you, Susan and Dr. Ongore for that elaborate presentation and the answers provided and your responses to the questions from the participants. I don't know whether there's any other burning issue that the team needs to address from the participants or from the attendees for this webinar.
Dr. Godia, maybe just to add a little bit, as maybe we are aware in a presentation, sometimes you do not end up having all the information that is required. I think I would like to encourage participants to, when we eventually have the final report, which will contain more details, maybe I would welcome colleagues to look at it, or if there are questions that maybe can be sent to us, we'll put our emails on the chat so that if there are any additional questions or even suggestions, especially in terms of recommendations, then I think those would be welcome. Thank you and over.
Okay. To a conclusion for this webinar. But I've seen in the chat, someone has asked a question about not being able to receive any CPD points. Is there anyone from the KNH medical research who can respond to that?
I think the answer is already there.
Oh, my answer.
Yeah,
okay.
He has been asked
okay.
to send an email to knhcpd@gmail.com for further assistance.
Yes, I believe this was a CPD accredited.
Yeah, okay. So thank you for that response. I have not seen it. Yeah, so thank you very much, Dr. Ongore and Dr. Susan, for the work that you have done. Also, thanks to Professor Wangombe in absentia. So this work also provides more insights in what the communities are thinking about the information, where they're getting information about COVID-19 and the information that we are providing out there. I hope there are findings that are going to support our public health communication, especially with regards to providing information out there with regards to COVID-19. What I see is coming out of these studies that communities are saying that we need to engage them on what the government or the authorities are coming up with in terms of these measures. So they need some engagement and communication so that, if we want to adherence and compliance, we have to have that aspect of engagement so that you are able to dispel some of the misconceptions that may be out there. The issue of Dr. Ongore talked about the issue of wearing masks and the importance. One of the other things that I would just say is that when we wear our masks well, and ensure that we are covering our nose and our mouth, it also limits the touching, yeah? The way you have to touch your mouth, you have to touch your nose, you have to touch your eyes. It also helps you become also more aware of yourself and of your actions. Because most of the time when we are touching our nose and our mouth, it's a kind of a reflex reaction. You are not able to think that you're going to touch your mouth and your nose. But when you're covering your nose and your mouth with the masks, I think it helps in keeping the hands away from that area. So there are some areas, I think there's some studies which are also upcoming. I know there's a study which is upcoming and it will mainly look at the qualitative component, looking at what people feel with regards to the adherence to the public health measures. So I think that is something that is in the pipeline, and it will help support the findings that Dr. Ongore and Susan have presented to us today. So I would thank all of you for being in the webinar today. And
Dr. Ngodi, I see 3 hands are up. I don't know if maybe the issues have been addressed.
Okay, let me see. Hands are up, yeah?
Yes, I can see Karina, I can see Alex Mutugi, and I can see Daniel Mukwana, and Janet Mumo's hand has just gone up.
Okay, so we have, so we can start with Karina. Your hand is up. I don't know whether you're able to unmute your mic from your end. Okay, so as she tries to come onto the session, what about Alex Mutungi? Are you able to unmute your mic? Give your comment or ask your question. Daniel, I think if you've raised your hand and you are able to unmute your mic, I think please just go ahead and ask your question.
Looks like maybe they are not able to. And just on the Q&A, there's Danish Magomere, who is raising the same issue around not getting CPD points. The answer was given. I hope you are able to get it and would be able to write an email to knhcpd@gmail.com for further assistance. Those who are looking for CPD points, please get in touch with the knhcpd@gmail.com. Thank you.
I have got a question on my phone. It says there that was there a gender analysis done? Yes, there was a gender analysis that was presented right from the beginning, but we have not concluded that part of the analysis yet. So as we said, this is very preliminary information. When we get that done, then we will be able to give you that information. But for the time being, that analysis has not been done. Thank you. And out. Okay, so Pamela.
Yes, I had given an opportunity for the people who had raised their hands to say something or make their comment, but we have not gotten that response yet.
Maybe they can type and send to us.
Yeah. Yeah. So hello. If not,
hello.
Yes, Jones.
Yeah.
Yes,
my
Jones,
question also comes. My question is about the age factor, because we found out on this side mostly the ones that are more aged, for example, 60 and above, they lived in ignorance that they used to say that there is no need for them covering their faces here and there. So I don't know when they were doing the analysis, did they touch on the age factor? Thank you.
Yes. 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 Thank you. Thank you very much for that. Yes, we've noted the different ages of in the rural and the urban, and the rural was more age. There were more higher age brackets than the urban. But we have not done that part of the analysis yet, and we'll definitely look at it and see what is the impact of age on the responses. So that is our next analysis. Susan?
Yes, you're right in that in the urban areas, I think most of the respondents were below 30, whereas in the rural area, most of the respondents were over 50. And I think most of the time when it comes to studies that are conducted through the phone, usually the concern is that the elderly maybe do not have phones. But the unique thing about our study is that, you know, it was an oral interview, only that it was done over the phone. So it didn't have to, I mean, it wasn't smartphone based or internet based. But you know, people were calling in, so it was possible in the rural areas to find the elderly, which of course is expected because the younger people have moved to the towns and cities to work, and so the majority there were different, and therefore some of this analysis is in the process of being done. But even just by comparing the rural and the urban area, it sort of gives a picture of what is happening where, given that the age bracket was pretty different in the rural and the urban. Over to you, Dr. Godia.
Okay, so thank you for that clarification. I hope you will be able to factor that in your analysis. Yeah, the age factor has come out strongly from this discussion. Yeah, so I am not seeing, Susan, I think you see the hands better. I'm not seeing any hand, but just before we, yeah, there's a hand there from, there's someone.
Githai's hand was up, but I think it has gone down. Now there's John's Wanda. I don't know if it's an old hand.
John's is the one who just asked the question about.
Yes, I still have another question. Or maybe a comment.
Yes.
That actually this material is very educative. So I don't know if it were possible after attending such a meeting, if at all we can get the information through our mails, because somebody like me, I volunteer teaching somewhere and they have given me that topic to teach. So it becomes so easy if I have material. For example, the research that we have just done, it can really be helpful to me. Is it possible after such a meetings, we be getting the material through our mails? Thank you.
Hello, good afternoon. Will you allow me to respond to that? I'm Dr. Karingo from Kenyatta National Hospital. The webinars and the presentations, you'll be able to get them from the KNH website. They're usually uploaded in the next 2 weeks. They'll be uploaded in the KNH website, and also there's a YouTube channel for the same KNH research. You just put in the topic and you'll be able to get the presentation. Once we have the presentation from the presenters, if they allow us to use the material and it's sent to our research email, we can be able to make arrangements for that to be for them to be disseminated via our emails for the presentation to be disseminated via emails once they give the permission to disseminate in that manner. Otherwise, we really appreciate the presenters. We really appreciate the webinar today, the information that we are receiving. And we really appreciate you, our attendees, for attending and for keeping up with us up to this time in the presentation. Let me hand over back to Dr. Godia.
Thank you very much, Dr. Karingo, for that clarification. Yeah, so materials are available, the KNH website, and for the actual use of the data itself, we leave that to the PI to give permission. Dr. Ongoro.
I have no problem. This is educative. If you disseminate this, the more people know about
depending on
these are not secret issues. These are issues that affect Kenyans. So the more it is discussed, I have no problem. And giving us also the way forward, which other areas we do need to look into. So it is part of our of our mandate of teaching and dissemination. Susan, I don't know what you have to say.
And nothing more. I think I'm in agreement. Once we finalize, I think even the preliminary one can be used with, maybe they just don't need to be disseminated, but I think we'll finalize that and be in touch with the KNH research team. Thank you.
Okay. Yeah, so I think that is clear. The materials can be used. And I think the only good thing to do is the acknowledgement of where the source of the materials came from. If you are able to use it, just acknowledge the authors of the research. Yeah. Okay, so we are coming to the end of this webinar. Thank you so much, everyone, for being there up to this time. We have Dr. Ongore and Susan they've taken us through the research and some of the key findings. And I think the team has also given some input on how the analysis should be done and some aspects that were not presented today, whether that can be explored, especially the gender aspect and also the age factor. And then in the discussion section, also just acknowledging other studies that have been done around the world and then seeing how this compares with the other studies that have been done in the same area. Yeah. So I think we have come to the end of the webinar today. I would like to thank everyone for sparing their time up to this hour to attend this webinar. Thank you very much, and hope to see you in our future engagements and our future webinars as they are shared to us through the KNH UN research emails that we have. I'm sure there are several webinars that have been lined up, so you will be able to attend. Hope you'll be able to attend those also in the coming days.
We have one on upcoming webinar tomorrow at 10 a.m. that will be covering COVID-19 and pregnancy. So be sure to tune in at 10 a.m. It will be running up until 12 p.m. You have the poster there, you can see the details, and we'll be glad if you could join us.
Well, thank you, everybody. Bye.
Thank you. Okay, thank you. Bye.
Thank you. Bye.
Bye.